Okay, continuing the topic, a cluster of cancers that is in every organ except the organs that are in the thorax, which means that it can involve GIT, colorectum, in female reproductive system, ovary, endothelium, and small bowel, ureter, brain, hepatobiliary tract, skin, stomach. So this is hereditary non-polyposis colorectal carcinoma. Now, what is the pathophysiology of this? It is mutation in the MSH2 and MLH1 genes. Okay, the younger ones are involved. It affects the right side, which means that most probably ascending colon, etc. There are adenomas, polyposis, not polyposis. What is the main pathology behind this? Is there is mutation in the genes that encode the proteins responsible, and these proteins are responsible for DNA during replication of DNA, for detection of any errored DNA, for excision of errored DNA, or repair of the errored DNA. So mutation in these genes encoding that proteins will lead to the hereditary non-polyposis colorectal carcinoma. Okay, now come to the third topic. This is hnpcc is also a major risk factor for adenocarcinoma of the colon. Now let's discuss adenocarcinoma of the colon. In this, there is it is a very most common malignant cancer with high morbidity and high mortality rate. It is actually the main third most common cancer in the US. Adenocarcinoma of colon, that is, adenocarcinoma means arising from the columnar epithelium. Okay, now what is the pathophysiology? It involves two factors, that is genetic factors and epigenetic factors. Now what in genetic factors, there is APC gene mutation. APC gene is actually a tumor suppressor gene that is actually the negative regulator of beta catenin gene. That is actually the negative regulator of beta catenin gene. So what is beta catenin responsible of? It is responsible for transcription and holding the cells together, which means that actually it is responsible for proliferation, and this gene is the negative regulator of beta catenin, which means that negative regulator of proliferation. So mutation in this gene will ultimately lead to the proliferation, uncontrolled proliferation of the cells, which means that leading to the cancer. I hope it's clear. And there are also some epigenetic factors. These are actually the post-transcriptional translational modifications. Now DNA is completely formed, it's unerrored, and this can lead to, but there is post-transcriptional modification, that is, for example, DNA methylation, and any error to this methylation will lead to epigenetic factors or mutations. Okay, the next factor is all the previous mutated cells will result in more number of mutated genes, that is KRAS. It will keep on growing, uncontrolled division of cells, and these proto-oncogenes, that are proto-oncogenes are basically the oncogenes, the genes that are not cancerous. Their malignant proliferation or mutation will lead to oncogenes, that is mutated genes. Okay, now the KRAS, TP53, SMAD2 and 4, I will show you from the diagram. Now this is the diagram from the medium Robbins. This is normal colon, mucosa, submucosa, propria, and there is first state, that is APC gene mutation. Now this APC gene mutation will lead to the mucosa at risk, which means that the mucosa will be started affecting, and beta catenin, and second hit inactivation of the normal genes, normal allele as well. So this will lead to the formation of adenomas that can be sessile, serrated, or tubular villus type, and proto-oncogenes, and further accumulation of these genes will result in proto-oncogenes mutation. Further genes will be involved, that is KRAS, similarly other TP53, SMAD2 and 4, and overexpression of CO2, because this COX2 leads to the PGE2, prostaglandin E2 production, and this is responsible for cell proliferation. So there will be number of cells, increase in the number of cells, and this will all lead to the involve all the three layers and all the invading other structures as well, leading to the carcinoma. And there is telomerase activity. Telomerase is actually a tail structure that is on dividing is lost, but in cancerous cells they keep on dividing, and there is increase in the telomerase enzyme. So this was all about the colon cancer. And one thing you must remember is that there are two pathways. One is due to the APC gene, and all these APC gene will lead to the sequence of events. All these genes will be involved and lead to the cancer. Second cause is the microsatellite instability pathway. Now what is first you must know microsatellite stability. What is microsatellite pathways? Actually these are actually the normal repeating short DNA sequences, which means that suppose we have this sequence, and on replication we have got this, and in microsatellite instability we have got this, that is sizes, the size of the original one is shorter, which the sequence you have got, which means that the sequence you have got is shorter from the original one. I hope you got my point. So this is microsatellite instability, and this is stable. So cancer due to microsatellite instability mostly affects the right side of the colon, which means that ascending colon is involved, and the type of polyp is usually sessile serrated type. Okay, now what is the morphology? If the cancer is involving the proximal colon, which means they're ascending, so it is polypoid exophytic growth, like protruding from the lumen. And in distal colon there is annular lesions, which means that circumferential obstruction or growth is there involving the whole lumen. So this is termed as annular lesions that produce napkin ring constrictions, right? There are desmoplastic responses as well, which means that there is change in the size, structure and shape of the cell. Now what will be the clinical features of how the patient will present? If there is ascending, which means that MSI right side is involved and microsatellite instability pathway is involved, so there will be exophytic mass like this. I have shown you in the diagram. This is the ascending colon, this is appendix, and there is exophytic mass, and there will be pain and history of weight loss. No obstruction is seen mostly in these cases, but however this mass will invade the propria and other structures involving the epithelium, so and the underlying structure, so it will lead to bleeding and cause iron deficiency anemia. Now so the patient presents with the triad of this: anemia, pain and weakness in ascending. Now in descending type, as it is involving the the sigmoid colon, the descending colon, so it will be presented with lower left quadrant pain. There will be narrowing obstruction due to the the napkin ring constriction, that is the growth in left side is like napkin ring, so it will narrow the lumen, leading to the constriction, narrowing. Cramping is a major clinical feature. So this is how the patient will represent. Now what are the investigations and how will you treat the patient? Is that on colonoscopy, which is the most sensitive and specific test. Colonoscopy is that camera is inserted into the rectum and all the colon is seen through the camera, so polyps or type of lesion will be seen. Occult bleeding, fecal occult bleeding test, which means that feces will contain the bleeding. If there is under GI bleed, internal GI bleed, there is also a carcinoembryonic antigen, that is a tumor marker for this GI cancer, mainly the colorectal. There is barium anemia. Barium anemia is actually a contrast shown to see if there is any constriction, so apple core sign is seen. So from this picture I have taken it from Google. So this is apple core, like this there will be constriction, and this is giving the apple core sign. You can also do digital rectal examination, but it is very rare and not proven as much effective. There is also flexible sigmoidoscopy. Now once the diagnosis is made, surgery is the treatment of choice. On staging, depending on the stage and invasion, there is chemotherapy, radiotherapy, follow up, you must see there should be regular checkup of CEA and T-gen tumor marker. Colonoscopy should be done after 1 year. Annual CT scan of abdomen and pelvis. This is all about colorectal cancer. Now, what are the risk factors? I have discussed it previously, that IBD, FAP, hnpcc, adenomas, high carb diet and fat, low fiber intake, because it will lead to the mutation in the alteration in the microflora of the gut, and will lead to the oxidative reactions leading to inflammation and other structures leading to cancer. This is all about colorectal cancer. I hope you liked my video. Please subscribe to my channel, it will be a huge favor. More videos on the way. Thank you so much.